Oh, good. So this is Senate Health and Welfare. We're back live. We've taken some terrific testimony on S-197 and have a lot to digest there. And now we're moving on to S-190, the Act relating to Green Mountain Care Board reference-based pricing and hospital outsourcing of clinical care. We have, we'll start with Devin Green of the hospital, and then we'll just move through our folks who are here to testify. We can learn what we need to learn.
Okay, give me one moment. I'm gonna get it up on Zoom. Yeah.
You okay? You having trouble with it? There you go. I just would like to announce we have an honored guest who is going to come in. Oh, sorry. Former senator.
Yeah.
Jeanette
At
White.
least I didn't fall in this.
No, exactly. Have a seat.
No,
Yes,
Yeah.
yeah, right here, but I'm just. like-
oh, that was your.
Yeah, same here. You're good.
All right. This is she's a critic, so we have to be really.
Yeah, very careful here.
Good to see you. Okay, all right, so we're on 190. I don't, I think we have what you are putting up, right?
Yes.
Yeah, we should.
Okay. Great. Thank you for your patience. My name is Debbie Green. I'm with the Vermont Association of Hospital and Health Systems. And thank you for having me in today to discuss S-190. I will first start with section 1, the reference-based pricing reporting. The idea here is the bill proposes that hospitals report their prices as a percentage of Medicare or other benchmark that they set. Conceptually, we do not have a problem with that. I think what we'd like to do is just get a very clear set of process or standards around this, or see if it's possible for the Green Mountain Care Board to. I think we just want to talk this through a little bit more, because one thing we're finding with Act 55, the prescription drug cap bill, which is essentially reference-based pricing,
Yeah.
is that there's we really do want like one source of truth and very specific instructions. Like as we dug into that, we found that there's multiple postings of the prices and which do we follow, and we just want to get very clear. I think this is a chance, you know, over the years, we've heard that hospitals report their budgets in different ways and there's no standardization. And I think our ultimate goal is standardization for this. And so whether that is like a process to get a very clear equation of how to do this, or the Green Mountain Care Board posting the prices, and that we put those in our transparency reports. Like, we are happy to work on this. We get the concept, we want to do it. We just want to make sure that we don't fall into another space of each hospital is tweaking things a little bit differently. Because as you can see up here, Medicare pricing, there are actually lots of factors in a Medicare price. So, so that's our thought there. And then sections 2 to 5 with the hospital outsourcing. The first thing I just want to address is, and this can be a little bit of, I just want to address that hospitals have been very upfront with a lot of their outsourcing. We've had newspaper articles about the company coming into the emergency departments. We haven't been trying to hide anything, I would say, with this. I understand that there has been differences in reporting, and the Green Mountain Care Board wants to get its arms around that, and I hear that. So I don't think we have any issue with the reporting piece and really standardizing and making the reporting clear. I think you'll hear from Blue Water and Brattleboro Memorial Hospital later about some of the issues this may cause for some of these organizations that are outsourced to and come in to the hospital. I think what we have here is the tension of some of these outsourced companies provide care at lower costs and better quality, and take out the difficulty of recruiting for providers and are able to help the hospital out. And do we want to, are we setting up a system where we're making it very difficult for these companies to come in? We want to make sure that there's a good balance between the ability for good companies to come in, help hospitals save money, help increase quality versus, sort of making Vermont not attractive to those companies. So I think reporting and very detailed reporting is a good start there. And then the Green Mountain Care Board can decide where it will go with the hospital budgets, but sort of like capping those companies themselves. Because they're underneath the hospital is could keep companies from coming into Vermont. And again, you'll hear from Blue Water, which is one of those organizations later. But my proposal would be, very transparent reporting in this space, because I understand the Green Mountain Care Board's concerns. Section 9, the appeals piece, the Green Mountain Care Board under statute was required to have an internal appeals process. They are taking that out with S190. I do have concerns around this from the very beginning. The hospital budget process has been a bit cloudy, and we actually had a hospital lose a case at the Supreme Court level because there wasn't sufficient objection during the process. And later on, they went back for a similar issue, and they actually won the case on the merits once they objected. But because there's no internal appeals process, I worry about the ability to create a record. I think it would actually save us from having to go to the Supreme Court. So I don't necessarily understand why we would take that away, and I would ask for an internal appeals process and greater clarity there. Hospital investigation and audits in section 10. The proposal here is that the chair of the Green Mountain Care Board can investigate and audit hospitals when reasonably necessary or helpful. And we do oppose this section. This was apparently sort of taken from the insurance laws by the agency that licensed them. And there are limitations around that in the insurance space. For instance, every 3 to 5 years, or for purposes of investigating violations or complaints. And here with S190, it's very broad. Whenever reasonably necessary or helpful is a very, very broad standard. In addition, we have our own state hospital licensure through VDH. They come in to inspect our hospitals. Hospitals have to have their accounting records of all operating and complete operating and financial statements available to VDH. We have DEVA investigating Medicaid fraud and abuse. We have federal hospital oversight from the federal government that includes the Office of the Inspector General that investigates fraud, abuse, and inefficiencies. There is a lot of oversight of hospitals, and I will tell you that these instances where these agencies come into the hospitals and investigate are very disruptive. There is a disruption in terms of the flow of the hospital and the daily tasks. There is a high stress level that's involved in it. And we understand that we're highly regulated. We do all these things, but I just want to emphasize that they are no small instance. It is not a small thing to come in and be investigated. And the sort of like reasonably necessary or helpful standard is really broad.
I have a question that is probably both for you and the board going forward, and that is, if this were not a part of the bill, if there were not an investigatory bill, even part of the board. I guess this is a board question, but the board could send a notice to the Department of Health or DEVA or others.
I mean, the board actually has the ability to go in.
Encourage an investigation rather than to initiate its own investigation.
The board has the ability to initiate its own investigation by sending in an observer. You passed that last year in Act 49. And it's when a hospital either materially misrepresents something or it's materially not compliant with the budget. My understanding of that is if a hospital budget is off by 1%, they are materially not compliant with their budget, which is essentially, I mean, can you tell me a budget that is on by less than 1% the entire year? Like, this encompasses essentially all of our hospitals. And if they are within 1%, then they should that in and of itself is a very broad standard. The other piece I would just highlight is Act 49 of 2025 is more in line with the actual governance of the Green Mountain Care Board, which is that the board itself is the one that appoints the independent observer. And in this bill, it's the chair of the board appointing the independent observer. And, I know in other agencies there are commissioners, but the Green Mountain Care Board, their leadership entity is the board. And so I think Act 49, having the Green Mountain Care Board itself appoint makes more sense than just a chair subletting investigation. Section 11, we support it. We're just I'm using this as a blatant opportunity to promote something that VAS is doing, which is we have put together a health system performance tool. It should be available publicly fairly soon. I want to say in a couple of weeks, but it's probably more likely like a month or two. But we are really excited about it. Our board's really excited about it. They think it's going to be a really helpful tool for their own boards who govern them, and we're really looking forward to introducing it to you further when it's up and running. And that's all I have.
Thank you. Questions?
Yeah, getting back to, thank you, Devin, for the testimony. Section 10, going back to the audits. I think some folks are happy to see that the Green Mountain Care Board finally has some agents to maybe their change. And I'm wondering, do you have any proposed language? If you don't like reasonably necessary, is there another phrase or is there other language that you can potentially propose that might be helpful?
I mean, I think the language that you had with the law that you passed last year is pretty clear. It actually has a very broad standard, and it allows the board to, bring in a third party to do that work. And, yeah, the fact that that is an available tool to the board, plus this being available tool to the board, and in both instances, hospitals would also have to pay for them, feels like a lot. And so I would say Act 45 from last year provides the sufficient tool that you need. 49, sorry, 49. Thank you.
Right. Okay. Well, this is good. This is, obviously, there'll be a difference of opinion probably, or some nuance to this, so if we hear testimony from all of it.
Our house was currently audited professionally, annually.
Oh, yes.
Yeah.
They have their own audits every year.
Like professional CPA.
Yes.
All right. Thank you.
Thank you.
Good. And we have, Elena and Emily, are you wanting to test or Owen, how's that gonna happen?
I can speak to the audit piece really quickly and then I'll turn it, that's all.
I'm sorry.
I can speak to the audit authority piece and then I'll turn it to,
Okay, that's fine. Yeah.
just briefly. Thank you. My name's Owen Foster. I'm the chair of the care board. Just a couple quick points on the audit authority that I think are important for context. The Green Mountain Care Board already has subpoena authority. It has, to my knowledge, since the beginning of the Green Mountain Care Board, so we can subpoena and do investigations already. That's been there, as far as I know, for a decade. In the history of the care board, my understanding is we've issued exactly one subpoena ever. And I issued it to the ACO about some information on their compensation. It was appealed and one appeal. So in 15 years, there's been one subpoena issued by the Green Mountain Care Board, not a single subpoena to a hospital. We also have the observer authority that was implemented last year. We have never used it. And there was a very, very clear case last year to do so, and we did not use it. My point here is we are very judicious in these authorities. We are not flying off sending subpoenas around for fun. It's not appropriate to do so. So we are very, very cautious and thoughtful and mindful when we actually do exercise those authorities. The point that Ms. Green made about whether it should be the chair or the full board, the reason why the care board supported it being the chair is because it mirrors the subpoena authority. The subpoena authority that's been there forever is solely vested in the chair. And it's solely vested in the chair for good reason, which is the chair has run of the office. And it's very important for running the office to keep mindful of how we're using our limited resources. And you don't really want people who are not involved in running the office to starting all these investigations. So that's why I feel the subpoena authority is vested solely with the chair, and why we support this authority being solely with the chair, just so that they're similar. Then the only other point I wanted to make on the audit was, yes, they do have CPAs that do it, but the information data we get is not the same data that's necessarily audited. We get a lot of other information that's outside of what's audited by the professionals. And that data is often not presented the same or analyzed the same or we don't see the same data. I, as the chair, do not anticipate doing a lot of audits. They take a lot of time, a lot of effort, and it'd be very similar to the subpoena authority under my leadership and the observer authority. Very, very, my view is would only be used if truly necessary. And happy to answer any questions that turn to my comments.
Questions? Okay, no, we'll listen and then we'll have to circle back and decide how to work with this.
And actually, this brings point about the limiters on the audit authority.
Yeah.
I think what I would recommend is the language should mirror the subpoena authority. Not the observer authority, but the same, it's really investigation, so it should be the same language. I want it to be similar to what we do with subpoena authority.
Thank you.
Thank you.
All right. Sure, together it's fine.
Yeah.
You got our chair?
Okay.
One of you gets the comfortable chair.
Yeah. Waiting for that.
What's that? I
session.
haven't.
I know, right?
I'm supposed to have a list of what's on that. And I'm not very good at it, or not happened yet.
Good morning.
Good
I
morning.
think it's still morning. For the record, I'm Emily Brown.
Emily Verdi.
So we have submitted some written testimony, this morning. Last time we were in the committee, we were asked to submit a written document outlining, the suggested language as well as the reasoning behind that. So you should all have that, on your website. So just a few, points that I wanted to raise, in response to, Boss's testimony. So the concern about the reference-based pricing reporting, I think that's a valid concern. We want to make sure there's consistency among how hospitals are reporting this out. You will see in the documents, we submitted that there is a revised and proposed definition of, for section 1 of what the Medicare base is. So we're hoping that that adds clarity. We would also support language that required the board to issue guidance to hospitals, to make sure again that there's consistency between hospitals on how they're reporting out this data. For the appeals process concern, this is, so when the board, it's my understanding when the board was formed that this appeals process language was based on language that's similar to the PUC. That's what it was modeled after. So again, this is consistent with that language, and we feel that this is important to clarify. There has never been an internal appeal. So this is clarifying existing practice and how things have worked since the inception of the board.
So what I guess the question that arises, because there is no internal appeal process, sounds like the hospitals would like something like that. But is there any kind of a negotiation process that goes on before there's an appeal to the Supreme Court discussion?
There's the board hearing process, which is extensive, as I'm sure many of you know, and that is the opportunity for board members to ask questions, for hospitals to raise objections or other pieces of information which they feel are relevant to the board's decision making. So we view that process as the event where there could be the discussion, and if more facts are needed or more information, that is the time that it's entered into the record. We feel if there was an internal appeals process added, that would just add a lot of extra work to the board's already heavy workload, and then not add a lot to the process that's currently in place.
Thank you.
And so I know Chair Foster already addressed the audit issue, so I won't go into that. I will say that for the insurance statutes, which some of this language was pulled from, Boz mentioned that it is a 3 to 5 year requirement for audits. That is because insurance companies are required to be examined every 3 to 5 years. There is no similar requirement for hospitals. So I just wanted to clarify that it's a very powerful tool. It's something that, as Chair Foster mentioned, the subpoena power has not been exercised acceptably. And I think it's understood how, that's a large responsibility, but it's also important, especially as we shift and think about compliance with our budget orders and wanting to make sure that when we put an order out there that the hospitals are actually complying. And I think those were all my.
You've given us really extensive comments and backup information.
Yeah. So I wanted to shift now to if there are any other questions on my comments. I wanted to give Elena time to speak towards reference-based pricing. We put in some additional information into this document that wasn't brought up before. There were questions about the caps that we originally suggested. So I'll turn to those.
Yeah, so I think, and I'll just go back to the definition for a moment as well. I think this definition is kind of a working definition, and we would expect as we continue to develop the rule that we would want to update that, and that would be kind of the source of truth. So I think this definition that we have here is kind of our first, take, and would give us at least some general consensus around what we're talking about for these first couple sections. So I think, on the consumer, the price cap, so I think section G, consumer price protection ceiling, we initially had proposed a cap of 500% of Medicare for any particular service. This was based on recommendations from Mike Smith. We've been working with the network and kind of looking into their operations. We know that some prices kind of are upwards of 700 or 800%, even 1,500%, which is really, if we think about
was quite a bit higher than what Medicare pays. We had extensive discussions during yesterday's board meeting. We heard from Medicare payment experts and others in the field who have done reference-based pricing and have learned from it. And they, you know, opened our eyes to some other ways of thinking about starting. So another option could be to start with service lines. It could be to start kind of in aggregate, kind of bringing down these outliers. Some estimates that Rand put forward, or sorry, that not Rand, Christopher Whaley used to work at Rand and now at Brown, put forward with Roz Murray was to think about, you know, more of an aggregate approach as a year one, and they modeled some savings associated with different levels. So if you take kind of 500 in aggregate, there's really no effect on hospital spending. If you go down to 400, there's an average effect around 92 million, but you have the detail for 9 million. You have the details in here for those different thresholds. This is not analogous to the original proposal, which is bringing down the service level that we talked about. That would really require hospitals to kind of generate estimates for us to understand specifically how it would impact their budget. Another option that other states are exploring that was put forward was to think about establishing a cap for out of network prices. So it's another way to kind of start, but it's different than the authorities that we are given. My question. So I'm happy to answer any other questions, but I think, you know, the challenge here is really having the detailed data to provide estimates of impact. You know, that's why we're doing this, contracting for assistance to do that modeling. And we want to make sure that we move the needle, but we don't move too quickly. And I think that is our concern with, you know, giving you something really concrete and objective here. But I think if hospitals were able to kind of help us understand how it would impact their budget, that might be a way to.
Well, this is good to hear you say, because I think in the original proposal, when you asked to have a bill introduced, there was a definite number in there. And I took it out because I said, you can't do this right away. So now it sounds like we're on the same page. You do have the authority to put some reference-based pricing in. You have the authority to do all of it. So, but there are some steps that could be taken sooner than later. My concern, I think all of our concern is that putting this off doesn't make a whole lot of sense. I see you saying, yes, good, or on the same page, it's good. For me, that's good. Questions? That we answered the question. So this isn't the last time we'll be looking at this bill together. It sounds like there are some things we need to balance out between hospitals and board and try and get to a good place where nobody's happy and all be happy. Yeah, it's good.
I just had one other comment that I failed to mention earlier. So there were concerns raised by Vermont Medical Society on the healthcare provider bargaining group language that we had put in there.
Yes.
We have a meeting set up to have a discussion with them on the language that's in there. So I just wanted to update you and let you all know that we're working on that. And we also have other suggested language that's on the proposed language adjustment sheet that we submitted on revision to sections 11 and 12. And essentially what it does is it just broadens the scope of the tool that we had originally outlined. We want to make sure that we have the ability, if we want to add additional topics to cover. So the proposed language, again, just expands that into topic areas instead of being very restrictive on what information we're going to put out there. So I just also wanted to draw your attention to that suggested language and answer any questions if there are any.
We'll take some time to look at it. No problem. We'll get to mark up on the bill and then Jen will help us interpret everything we've got. So, good. Thank you so much. Thank you, Devin, and also thank the board for the very specific comments on the bill. This is how we can make it happen, and also for the hallway conversation.
Yes. Yeah.
Okay. But we do have two more folks who testified. Dr. Ada Abdick, did I say that properly?
Hi, good morning. Good enough. Aida Avdich.
Oh, there you are. Okay, great. So Dr. Abdick, from Brattleboro Memorial Hospital, we would like to hear your comments. Thank you.
Thank you, Chair Lyons and the rest of the committee. Thank you for having me here and allowing me to testify. As you've heard, I am at Brattleboro Memorial Hospital. I am a practicing physician, hospitalist here at Brattleboro Memorial Hospital for the last 14 years, and chief medical officer at Brattleboro Memorial Hospital for the last year. I am here to provide testimony with regards to S190, in particular to the section relating to the hospital outsourcing of clinical care. While I think this bill is well-intentioned, it will unintentionally harm rural hospitals' ability to secure adequate and high-quality staff for.
Dr. Abdick,
Yes.
could you speak closer to the microphone?
Absolutely. Is this better?
Thank you.
Thank you. As I was saying, while this bill is well-intentioned, it will unintentionally harm rural hospitals' ability to secure adequate and high-quality staff for critical 24/7 services. Community hospitals and rural hospitals face significant challenges in recruitment and retention of adequate clinical staffing to maintain 24/7 essential clinical services. The workforce has changed through the COVID-19 pandemic, particularly in the rural areas. Aging workforce, including aging workforce in Vermont of physicians and advanced practitioners, means that hospitals and healthcare facilities are competing for limited resources at this point, and small rural hospitals tend to be less competitive and attractive to new employees. Housing costs and limited housing availability has proven a challenge even for this skilled force to enter work in Vermont. And practice patterns changes of today's clinicians who are looking to structure their practice in such ways that lead to less call time, in particularly impact rural staffing models, where inherently there's a higher need for call coverage compared to more urban or high volume areas where 24/7 coverage can be spread across a larger group of clinicians. So this leads to rural health systems to seek innovative ways of staffing 24/7 services and reliance on several types of partnerships to fulfill this need. When we think of outsourcing, we have a lot of negative connotations. It often is associated with, job loss, with loss of community ties, with loss of control or handing over responsibility. That's not how community hospitals see our partnerships, and we consider this partnerships with vital partners who provide essential services for our patients in our community, rather than outsourcing. Community hospitals need to maintain this agility and flexibility to provide adequate and high quality staffing to maintain 24/7 clinical services. I want to highlight a couple of areas that BMH has worked over the last decade and longer to maintain these partnerships in order to preserve essential services for our communities. One of those is in the area of pathology. We have partnered with UVM to provide high quality pathology services that allows for more flexible, high quality 24/7 care. For BMH and its patient, it provides access to high quality services, and it allows us to share pathology staffing across the Vermont. And additionally, it is more cost effective for us than a direct employment of at least 2 to 3 pathologists, which we can't even recruit in order to maintain 24/7 access to this critical service. Another area that we have partnered with a different organization is in radiology services. Again, 24/7 need for a community hospital. We've partnered with the HMC, and again, sharing radiology staff, sharing their resources and benefiting from their expertise and 24/7 availability and their quality assurance programs and quality of radiology reads. Another area where we had to seek partnership was in providing anesthesia care. In the midst of COVID-19 pandemic, our local independent small anesthesia group, which partnered with BMH for decades to provide perioperative anesthesia services for our patients, including 24/7 emergency coverage for emergency surgical patients and emergency obstetrical cases. They rapidly dissolved after a death of their leader. We were left to scramble to provide adequate 24/7 coverage for such essential service. We were able to partner with a CRNA group to maintain this essential service for our community. These are some of the example I'm using. The most recent one is our partnership with Blue Water. Again, in the same vein, we had a partnership with a local with a DHMC to provide 24/7 ED physician and advanced practitioner coverage. They notified us that they no longer could support us, and we had to pivot and find this coverage again. It is very difficult for small rural community hospital to recruit adequate staff, enough human beings who are willing to staff 24/7, 365 days service in a very short notice. On average, it takes a hospital 9+ months to recruit any skilled clinician. So we were given about 6 to 9 months notice. There is no way we could recruit everybody, and we had to turn to organizations who have agility and ready-made ability to provide that staffing at quality level that we want and at a cost-effective level that Vermonters and our patients deserve. I am concerned that the current language of S-190 bill would significantly jeopardize small community hospital ability to maintain and restore essential clinical services in these situations. As I mentioned, it takes at least 9+ months to recruit a single individual at this skill level. And maintaining 24/7 services requires more than one individual. And some of these groups are a lot better positioned to recruit, to retain, to maintain high professional standards than individual hospitals could at any given moment. The benefit of this for our community is that these people actually work in our communities. They move into our communities. They become members of our communities. They are, as professionals, part of a group of like-minded individuals with the same mission, same drive, and are able to maintain their quality standards, professionalism standards, and have connections rather than being a small isolated practice or hospital employed. I am concerned that requiring additional regulatory burden, requiring reporting under the hospital budgets will drive some of these smaller groups out of Vermont, as it's going to pose additional burden in terms of reporting, in terms of financial compliance, in terms of many other aspects that will not be palatable, and these groups will leave Vermont and ultimately leave small community hospitals scrambling to pay for either locums care, which is 3 times more expensive than on average than regular hires, and often comes at the expense of quality and investment in a community. So I will end at this. I have provided written testimony with some more details, and happy to take questions.
Thank you for your comments. And our time has gotten to be precious right now, but I do have a question for you. We're going to hear from Blue Water next, which will be helpful. But at some point, it would be helpful to understand how you are working with the Act 68 Agency of Human Services and board and transformation, regional transformation. Don't have to do that right now, but it is a question that I have, which I think will be helpful to us.
Okay.
Yeah, thank you. Thank you for being available and being patient. So we'll move to Jay Mullen, who is President and CEO of Blue Water Health. Jay, thank you for being here.
Great, thank you. Chair Lyons, Vice Chair Gulick, and the members of the committee, thanks for this opportunity to meet with you, at least virtually. As you noted, my name is Jay Mullen. I'm an emergency physician at Brattleboro Memorial Hospital. I'm also the president and CEO of Blue Water Health. Blue Water Health is an independent, physician-owned and led emergency medicine group serving hospitals across northern New England. I also chair a national coalition called the Emergency Medicine Business Coalition, which represents 46 groups just like Blue Water across the country, where every physician has a pathway to become an owner in the group. So we're what's called a democratic group, meaning that our owners are our physicians, and our physicians are our owners. I'm here today in opposition to S190 as currently written, because recognizing that it's got good intentions, the unintended consequences would harm the very physician groups Vermont's community hospitals depend on for reliable, cost-effective 24/7 emergency care. I'm going to summarize my written testimony and really focus on 6 points. The first one is independent groups are essential partners. We're not cost drivers. Independent physician groups fill critical staffing needs in emergency medicine, anesthesia, radiology, pathology, etc. Community hospitals choose groups like mine because we offer lower overall cost, higher flexibility, strong quality performance, and local physicians who are embedded in the communities they serve and believe in the hospitals that they work in. This really is not outsourcing in the corporate sense. It's local doctors caring for local patients, supported by the shared expertise across our 11 different emergency departments. For many Vermont hospitals, independent groups are the most affordable and highest performing group options available. My second point is that S190 undermines this model and makes recruitment significantly harder. When physicians join a group like mine, they are choosing independent practice because it provides local governance, professional autonomy, predictable compensation, and probably most importantly, to take part in a mission-driven, community-focused environment. By folding independent group revenue into hospital budgets and subjecting it to rate setting, S190 removes the stability and independence that makes these groups viable. This would make Vermont far less competitive at a time when emergency physician shortages are really quite severe across the state. It also means hospitals would lose access to partners with lean administrative overhead, efficient staffing models, and better throughput and performance metrics. The long-term result would be predictable. If independent groups exit, hospitals have to turn to either employing the physicians directly or depending on large national corporate staffing companies, oftentimes private equity backed, and the systemic costs increase. My third point is that S190 appears to be attempting, at least in part, to solve a problem that's already been solved by federal and state law. In January of 2022, the federal government passed the No Surprises Act, which completely protects emergency patients from balance billing, whether they're in network or out of network. So under this federal law, emergency patients cannot be balance billed. Insurers must treat all emergency care as if it was in network, even if it's out of network. And payment disputes, if there are any, occur only between the insurer and the providers. The patient is left out of that dispute. So there is no remaining gap in emergency billing protections that S190 needs to fill. Adding state level regulation duplicates a federal and state level framework that already works quite well. Fourth point, the bill reduces both patient choice and physician choice. If Vermont becomes inhospitable to independent practice, physicians will choose to work in neighboring states with more supportive regulatory environments. That would threaten Vermont's ability to recruit and retain the very clinicians that the community hospitals need to keep functioning. That would lead to less diversity of clinical expertise, less local involvement, less innovation, fewer staffing options. And all of those that is all the opposite of what Vermont's rural healthcare system needs. And this leads me to 5.5, which although I've been pointing out the frailties of the bill, I do agree that oversight is appropriate. But the approach as outlined in this bill is overly broad and counterproductive. Transparency and accountability are important goals, but S190 applies a regulatory structure designed for hospital departments and applies it to independent physician-led groups that consistently already reduce cost and improve performance. We already show this through shorter lengths of stay, fewer patients leaving without being seen, strong community integration, strong integration into the hospital leadership framework, and lower overhead than hospital employed or corporate models. These are the partners that Vermont should really be supporting, not sweeping into a regulatory framework that makes their work impossible. So point 6 I'd like to make is that in my opinion, there's a better approach in this area. Vermont can achieve its goals without dismantling an already functioning cost-effective staffing model. More targeted solutions could include requiring disclosure of outsourced contracts, as Devin mentioned, without merging those independent group revenue into hospital budgets. Applying consistent financial assistance policies without redefining independent groups as hospital entities. Recognizing that federal law already protects patients from surprise bills. And lastly, preserving hospital flexibility to choose the staffing model that best meets their local needs. Independent groups are part of the solution, not a driver of the problem. So I would urge you to consider rewriting or voting against S190 as it's currently written, because it would unintentionally drive physicians out of the state, reduce hospital staffing options, raise long-term system costs, and shrink patient and physician choice. Independent physician-led groups deliver high-quality, cost-effective, community-based care, and we should be aiming to protect those staffing models, not undermine them. Thank you very much, and I welcome any questions that you might have.
Well, thank you for this, and you've given us 6 critical areas to think about. We appreciate that. And again, I think it would be helpful for us to understand the work that Brattleboro is doing and with the transformation process overall. Because our goal there was to ensure financial sustainability and make certain that some of the problems that hospitals are seeing don't persist. So at some point, it would be good to have you folks come back in and talk about that. So, but thank you for today. We appreciate it very much.
Thank you.
Thank you.
So we're 15 minutes off schedule, but we're going to do everything we have to do. We're going to hear first from Sandy McGuire of Howard Center, and then we'll move on to the S163. We wanted to talk with OPR briefly about that. Well, yes, we have, and we need to finish. I'll quite that. Welcome.
Thank you for having me.
It's good to see you.
It's good to see you all. Thank you for all you do. I sit here and listen to these conversations in advance, and I'm just mindful of all the information that comes into all day long.
Together.
So, appreciate the opportunity to be here. Chair Lyons and members of the committee, thank you for the opportunity to be here, and especially for the attention on Mental Health Advocacy Day. All sorts of good conversations happening in the building and next door, and a lot of appreciation for the folks that do the work in this house every day. So I extend that on behalf of lots of my friends and colleagues next door and in this building. For the record, I'm Sandy McGuire. I'm CEO of the Howard Center. And I want to begin with a story that was shared with me just a couple of days ago. A parent reached out to reflect on several years when their child was experiencing a prolonged mental health crisis. During that time, the family interacted with hospitals, emergency departments, shelters, law enforcement, state agencies, and with the Howard Center. Those years were exhausting and frightening for the family, but today, the young person has been stable for more than 3 years. They're doing really well, and they've got strong supports in place. And as the parent reached out, they also wanted to update on or describe their role during that time. And they used an old Roman word, benefactor, not just in the sense of financial help, but as someone who could advocate, persist, push systems to communicate, and stay engaged when things became overwhelming. They also acknowledged something important. Most people who come through our doors do not have that kind of advocate. They don't have family with time, resources, or influence to navigate multiple systems at once. And that difference between having an advocate and being alone is often the difference between stability and crisis. Howard Center is the designated community mental health and developmental disability agency for Chittenden County and a preferred provider for substance use services. And along with our peer designated agencies and specialized service agencies across Vermont, we operate as part of a coordinated statewide network, Vermont Care Partners, ensuring that in every region of the state, there's a provider responsible for delivering essential community-based services. Designated agencies deliver Medicaid entitlement services required under Vermont state plan, and we also provide additional mandated safety net services that our communities rely on every day. We are not simply one provider among many. We are part of Vermont's public mental health, substance use, and developmental services infrastructure. We're required to serve individuals regardless of complexity, acuity, risk, or ability to pay.
When systems are strained, when needs are severe, and when options are limited, designated agencies do not get to opt out. We work in close partnership with hospitals, schools, law enforcement, shelters, housing providers, and community organizations. And that coordination is not incidental. It is absolutely core to the model and core to our success. At the Howard Center, that responsibility translates into real scale. Each year, we serve more than 19,000 Vermonters across the lifespan, children, adults, families, and older adults. We provide services 24 hours a day, 7 days a week, 365 days a year, because crises and essential services don't follow traditional business hours, as we all know. With more than 1,300 employees, the Howard Center is the fourth largest healthcare employer in Vermont. Our staff work across outpatient care, crisis response, residential services, and community supports, often behind the scenes, but essential to the functioning of our healthcare and public safety systems. Our services include outpatient mental health, substance use treatment, emergency and crisis response, school-based and family supports, developmental disability services, and community-based housing and support programs. And what ties all of this together is continuity. People rarely experience challenges in neat categories. Needs change, crises emerge, recovery and stability takes time. Our role is to stay with these people as their needs evolve in whatever capacity, and to do so in the community whenever possible. Over the past several years, the work has become more urgent and more complex. We're seeing higher acuity across the board, and particularly among children and youth. We're seeing increased co-occurring mental health and substance use needs, and more people whose challenges are intertwined with housing instability, medical issues, and involvement with emergency systems. As Vermont's population ages, we are increasingly supporting older adults experiencing depression, anxiety, cognitive decline, and mental health impacts of isolation, loss, and medical complexity. These needs often intersect with housing, caregiving, and healthcare systems, requiring coordination in that community-based response. At the same time, workforce shortages and financial constraints make it increasingly difficult to meet demand at the level people deserve. And despite this, our staff continue to show up. Clinicians, crisis workers, case managers, residential staff, direct support professionals, doing work that is emotionally demanding, often under-recognized, and absolutely essential. Much of what designated agencies do is the hardest work in the system. We provide services that are high risk, labor intensive, and available around the clock. We serve people in crisis, people with the most complex needs, and people who have often been turned away elsewhere and have nowhere else to go. This work is among the most difficult and the least financially supported in our healthcare system, but communities cannot function without it. It is precisely this work that keeps people out of emergency departments, reduces involvement with law enforcement, stabilizes family, and supports community safety. Howard Center has served this community for over 160 years, and that history is not about preserving the past or standing still. It's a constant evolution. Across generations, we've adapted to new clinical knowledge, new community needs, changing expectations, and increasingly tight fiscal environments. Today, like many providers and the state itself, we're facing difficult choices. Resources are finite, needs are growing, and trade-offs are real. We've had to make difficult decisions. In some areas, that means reducing or ending programs that are no longer sustainable, while at the same time, we continue to evolve to meet emerging needs, partnering and leading new initiatives, such as the mental health urgent care, a recovery shelter, and a new specialized program for military members and veterans. These efforts reflect our commitment to adapt, even in constrained environments, in service of community need. Our responsibility is to steward the resources entrusted to us in service of our mission, making careful, often difficult decisions so that within the resources that are available, we achieve the absolute greatest impact for the communities that we serve. Mental Health Advocacy Day matters because the decisions made in this room and in this house are not abstract. They shape whether Vermonters receive help early or only once they reach crisis. They determine whether families must act as full-time system navigators or whether care is accessible and coordinated. They determine whether designated agencies can continue to meet our mandated responsibilities safely, sustainably, and effectively. Mental health, substance use disorder treatment, and developmental services are not separate from healthcare. They are foundational to it. As your work continues in this session, we respectfully ask that you support stable and adequate funding for community mental health, substance use disorder, and developmental disability services, so access does not depend on crisis status or geography. Invest in the workforce through recruitment, retention, and competitive compensation. Strengthen prevention and early intervention, especially for our children and families and older adults. And continue building alternatives to emergency departments for mental health crises. These investments do more than improve individual outcomes. They strengthen families, reduce strain on other systems, and support healthier communities across Vermont. And I want to close by returning to that parent who reached out to me. They expressed deep gratitude for the people who showed up during their family's hardest years, often quietly, often behind the scenes, and often under extraordinary pressure. That is the work of designated and specialized services agencies. It's complex, it's challenging, and it's essential. We are proud to do this work on behalf of Vermont, and we're grateful for your partnership in ensuring that when people reach out for help, there is a system that is ready to meet them. I appreciate your time. I know it's tight. Happy to answer.
It is tight,
questions
but
if you
this is really important. We haven't had an opportunity to talk about our community-based services. And today is Mental Health Advocacy Day. And I know that Carrie Kelly will be talking with us a little bit later. But I thank you for that summary, and thank you for the work in particular on the mental health clinic that now has reduced the pressure on the emergency room in Burlington, which is just outstanding. But thank you for your work.
Thanks, Senator. And I think mental health urgent care is a great example of what we do with our partners and how we take the limited resources and stretch them that much further. And when we bring together the hospital, the designated agency, our FQHC, and our peer agencies, and we all bring what we do best, incredible things can happen and make a real impact. So
And we didn't have to do it. This is the best part for me. It just happened organically. Thank you for that. So, we are going to move on to S-163, and we asked OPR to come in and talk a little bit about the APR and bills with us. So sorry. Hello, you both want to come up, or have you?
Well, actually, Lauren
Oh,
here
Lauren's
is with us.
They're with you. Oh, good. Okay.
Spread on my shoulder.
All right. Let's move her. She's still.
Good morning.
Good morning. Go ahead.
Good morning. For the record, my name is Lauren Hibbert. I'm the Deputy Secretary of State for Vermont, and I have with me
Jen Cola, I'm the Director of the Office of Professional Regulations. Hello.
Okay, to be regulars.
Yes, every day.
we feel honored to be here every day. And on every issue that you have. But we don't have additional testimony. What we understood is that there were additional questions that you folks would like answered about APRN scope of practice, how it intersects with hospital certification, and why we are asking you to remove the consulting with a physician language from this bill. So I'm happy to answer that question. Is that the core question that this committee has?
Yep, let's do that.
Okay. So, APRNs have independent practice. As you've heard, we're one of 27 states that do after you're fully credentialed as an APRN. This is really important for the fabric of Vermont's healthcare, that APRNs have this independence. They work in many situations, many places, and frequently in locations where physicians, both allopathic and osteopathic, work. It's important that in all healthcare professions, it doesn't matter whether you're a physician and you're board certified, whether you're an APRN and you have a specialty in, since it's Mental Health Awareness Day, you're a psych APRN and you're a prescriber, or you are an LPN. All healthcare providers do need to collaborate. It's very rare that one provider is the sole provider for a human. Humans are complex, and care, especially in facilities like hospitals, lasts multitudes of days. If there's a complex condition, healthcare providers need to consult with their peers to get additional perspectives. I'm saying something you all know. So all healthcare providers should collaborate with others. That being said, some hospitals have certifications that put additional restrictions around providers. Not all hospitals have the same certification structure and the way that they're providing oversight to all of their providers within their facility. Again, I'm not an expert in hospital certification. We're here because we are somewhat experts in APRN scope of practice. And APRN scope of practice is really determined, just like every other healthcare provider in the world, by what you've been trained to do. Sometimes it's because you have additional certifications, like a national certification as an APRN in psychiatry, you're a psych APRN, or you are a physician like my sister, and she's a critical care pulmonologist. She would be the first to tell you that's her job, that she would never do other areas of medicine. So you receive your core training, you receive additional training, and then you are really constrained, for the lack of a better word, by what you know with your current training. And that's true for every healthcare professional. And that is what we're looking to preserve, is that APRNs know what their scope of practice is, just like other healthcare providers do. APRNs know what the boundaries of their knowledge is, and APRNs know when to seek help. And we are just not asking that this bill doesn't have this restrictive language in it, because it will be seen not only by the APRNs in the state, but by APRNs in the nation as a step backwards. And we know that APRNs come to Vermont in part because they're able to practice at the highest scope of their license.
Okay, thank you for that. I do have two questions then. Can APRNs practice independently, open their own practice, given their scope?
Yes, absolutely.
And we have those in our state.
We do.
Would a hospital become staffed only by APRNs?
I don't believe that there's anything that would prohibit that, Madam Chair. I don't think that a hospital would do that because honestly, APRN scope of practice, as broad and large as it is, APRNs can't perform heart surgery. There's so many things that are outside of the scope and training of APRNs, that core functions that need to occur in a hospital.
So then the other thing that we heard from our APRNs the other day, and we just heard from you, is that they should collaborate. They need to collaborate. Is it required that they collaborate?
No. That's what we're asking that you remove, the requirement. They should. And we have prosecuted a dentist for failing to collaborate when he should have. We've prosecuted an APRN for failing to collaborate when she should have. It goes across all of our healthcare professionals. People get themselves, we call that the failure to phone a friend case. If you are outside of your scope of practice, your knowledge base, it is your job to seek collaboration and help from others. That doesn't need to be mandated. That's really commonly understood. And the way that this bill is written, it's not just that you would have to collaborate if you were at the outside edge of your knowledge and scope. It would be every time. And that's the piece that is objectionable. It's objectionable because it's mandating for every interaction as opposed to when you need it. And the when you need it doesn't need to be written in the law. It's happening all across the state all the time in every direction. And I would imagine just like APRNs consult with physicians, physicians consult with APRNs. And I have seen, as a patient before, a physician consult with an RN about my care. So that happens in all directions. I think the interplay and the roles in healthcare are so important. And this is a community that really knows how to figure that out. And that's why I don't think it needs to be restricted in the statute.
I have one last question, and that is, you indicated that some hospitals have restrictions on practice. So as part of the hospital's mission and their perspective, will the next step be that you want, that you'll challenge those hospital restrictions?
I don't think so. I don't think so, Madam Chair. I think that's what employers choose to do in their facility and who decides to work in a facility those are marketplace decisions that I don't think OPR would get involved in. I really don't think so. It may be that hospitals themselves want to shift those things and employers might want to shift those things, but I don't think OPR would be involved in that. It's just that if we see that without, the reason why we're here is just this is a universal restriction, not one by one hospital, as opposed to, and APRNs shouldn't be constrained, their scope shouldn't be constrained based on where they choose the setting. It can be based on which employer they have. That's a different thing than having it restricted by the state.
Okay, thank you for that. And then, is the Board of Nursing looking at, the Board of Nursing obviously is interested in this particular bill. Will the board also be considering hospital restrictions on, and within the bylaws, hospital bylaws?
No. That's so far outside of the scope of the Board of Nursing. The scope of the Board of Nursing is really just this. I shouldn't have used the scope. The jurisdiction of the Board of Nursing is really related to the scope and practice of nurses in the state, regardless of setting, in primary care, walk-in clinics, all the way up to hospitals. Not that primary care is less than a hospital care. I didn't mean to imply that.
We get it. Good. Yes. So all the questions that I'm asking are things that have popped up, like hallway conversation. So I think it's important to clarify what is in the bill and what's not in the bill, what's happening and what's not happening. Oh, this is very helpful. Appreciate your taking the time.
Anytime.
Other questions can be. And you know what? Every bill is more complicated than every. So
that's what makes it so interesting, Madam Chair.
Yeah, it makes it fun.
I think it's really fun.
Oh, we're good. We'll pick up 163 another day. We do want to get into a markup on the bill and look at it more closely. But we appreciate your being available to us in the way that you are.
Anytime.
We'll see you tomorrow. I know you will. Yeah, right? Yes. Okay. No, we're early. I think Carrie Kelly, you're